The Oswestry Outcome Centre on the first 5,000 BHR cases by 141 surgeons in 44 countries showed a 95.2% implant survival at 10 years. So what is my learning curve? Between 1991 and 97, I performed about 500 metal-on-metal resurfacings, and these have been reported. Then I carried out 500 BHRs, and these are the results of my first 500 BHRs, and you will see that at 10 years I have a 95.3% implant survival, which is identical to the Oswestry 141 surgeon study. Then I carried out a further 3,000 plus resurfacings, and my results are better, and they are 5% better at 15 years. So that shows a clear learning curve, and the learning curve for hip resurfacing is 1,000 cases. There are all my results, all ages, all diagnoses, 96.1% implant survival at 17 years. Obviously better than the new NICE guidelines. The new NICE guidelines are strictly applied to hip resurfacing results. Now, the NICE guidelines used to be an acceptable failure rate better than 1% per year. Now they have changed the NICE guidelines and gone to a much higher standard, and now they want a failure rate of 0.5% per year. So 5% failure rate at 10 years or better. I said these new NICE guidelines are strictly applied to hip resurfacing. Are they also applied to total hip replacement? I'm going to show you that the answer to that is no. Here are the results of total hip replacement in different age groups from the Australian National Register. Here you can see in patients older than 75 years that at 10 years there is a 5% failure rate. So patients older than 75 years having a total hip replacement do just meet the new NICE guidelines. However, for patients aged 65 to 74, patients aged 55 to 64, or patients younger than 55, none of those groups meet the new NICE guidelines. So if the regulatory authorities were treating total hip replacement and hip resurfacing by the same standard, then total hip replacement of all varieties should be banned and withdrawn for patients younger than 75 years of age. And clearly there does not seem to be an appetite to do that. When we break down the results by age and gender, men and women over the age of 60 do well, and men under the age of 60 do well. The problem area is women under the age of 60, and I want to show you why that is. When you look at this table, you can see the 229 women, or 31% of the under 60 age group, had developmental dysplasia. In addition, 3.1% of the under 60 women had avascular necrosis. When you look at the results by diagnoses, then the two worst diagnoses are dysplasia and avascular necrosis. The most challenging activity level are men and women with osteoarthritis under the age of 50 years. There are my results in both those groups, showing all causes of failure. When we just look at aseptic failure, women with osteoarthritis under the age of 50 have a 100% implant survival at 17 years, and men under the age of 50 with osteoarthritis have a 99.2% implant survival at 17 years. Men have large femoral heads, women have small femoral heads. In this publication last year, we reported our 12 to 15 year results of the first 1,000 Birmingham hip resurfacings. When we followed these patients up, unfortunately, we had over 20 patients missing, and I simply was not prepared to publish with over 20 patients missing. So with mailing and remailing the patients, contacting their known next of kin, and contacting their general practitioners, we managed to get the number lost to 8. We then hired a private detective agency, and after 1 year, they found every single patient. So we know for certain the outcome of these 1,000 Birmingham hip resurfacings. What about national joint registers? Do they have 100% follow-up? Absolutely not, is the answer to that one. In this publication from the London Implant Retrieval Centre, they linked the known revisions to the National Joint Register, and they were unable to link 39.1% of the revisions to the NJR data. Now, that was over a 10-year period, and the view is that the loss to follow-up has improved at the NJR, but last week at the Great Debate Conference in London, the view was that about 20% of data from the NJR is missing. So we are dealing with incomplete and less than perfect data. So we do need to be very careful before making rash decisions, given that 20% of data is lost. In this publication from last year, we showed that head size has no influence in men or women on the revision rate. Avascular necrosis is a significant risk for failure in men. Dysplasia is a significant risk for failure in women. This lovely lady dropped into my outpatient department 4 years after I carried out her right BHR with a 44 femoral 50mm acetabular component, just to tell me that 4 years after her surgery, she'd gone and won the World Masters Badminton Championships. Try telling this woman, or any other woman in my series with a BHR for osteoarthritis, that hip resurfacing doesn't work in women, and just see what sort of reaction you get. I'm going to talk about some failures of materials with hip resurfacing. This patient had an abnormal reaction by 4 years after her BHR that I performed, with bone loss in the acetabulum and the femoral neck. What have I done wrong? 24-hour output studies of ions is the best method of ion assessment, and this patient's metal ion output was no different to a well-functioning group of BHRs. CT scan showed that her angles were all fine, and she had an effusion in the front of the hip, and this was palpable clinically. Retrieval analysis shows no abnormal wear, and the wear patch on the acetabulum is right in the center of the cup. The only thing that was wrong was she was strongly positive to nickel. For the last 5 years, I've been working on a polyethylene cup hip resurfacing, and this is a picture of the first implant that has been inserted. By displacing the hip center laterally and inferiorly and combining it with an inferior cutout, you can get a little bit more acetabular wall thickness while still retaining a 6mm outer diameter to inner diameter difference. When you add even a 1mm porous shell, that does significantly reduce the wall thickness. There's a 1mm additive manufactured porous shell, and there is such a shell directly molded with polyethylene. When you do finite element analysis, there is quite significant strain concentration in the edge of the implant, right at the edge of where the porous shell stops. However, it is now possible to apply a porous titanium surface directly on polyethylene, and that is shown in the slides, and that is 150 micron thick. So there's the new cup with an impaction ball, and this fits onto a standard hip resurfacing introducer. This is the first patient. He had an ASR resurfacing and had a terrific result for 6 years. However, after 6 years, he got a metal reaction, a fluid effusion, and pain. He would not allow me to revise his resurfacing to a total hip replacement or any other implant, and the only thing he would allow me to do was to change his acetabular component. So I've taken out the metal shell of his ASR and put in a highly cross-linked polyethylene coated acetabular component, and you can see the post-op and the 2-month post-operative films. Happily, there is no movement that has occurred between post-operative and 2 months. You can see the RSA beads in the polyethylene, and you can see the 150 micron porous titanium layer on the outside of the cup. I now turn to joint function.
This is an excellent paper from Robert Barrack's unit in the United States, and this is a paper I recommend that you read. This is a multi-center trial to reduce the chances of selection bias. Men under 60, women under 55 years, a pre-morbid UCLA score of 6, minimum 1 year follow-up, and an independent third-party telephone interview using specific telephone survey instruments. There are the number of total hip replacements, about half of them less than 32 millimeters and a half of them greater than 32 millimeter heads. The resurfacings were mainly BHRs. Adjusted for age, gender and pre-morbid activity levels, hip resurfacing patients were significantly more likely to have never limped, not felt thigh pain in the last 30 days, less perception of having a leg length discrepancy, walked continuously for greater than 1 hour, tried to run the furthest distance, returned to higher level of activity, returned to their most favored activity with a UCLA of 9 or 10. But resurfacing patients did have more clicking, grinding, or popping noises than total hip replacement. This is the best laboratory study from Professor Justin Cobb's group in London. Patients are put on a treadmill and the speed is gradually increased up to the patient's maximum walking speed. They looked at 22 hip resurfacings, 22 total hip replacements, and 22 healthy controls. The controls and the hip resurfacings were broadly similar, but the total hip replacements were 9% slower. Mortality is lower with hip resurfacing compared to total hip replacement. This is our BMJ paper a couple of years ago, and this shows very clearly that the lowest death rate following surgery is with hip resurfacing. Intermediate results with uncemented total hip replacement. Highest death rate in red at the bottom is with cemented total hip. The response of the NJR to our findings was that they felt there was a conflict of interest. Professor Richard Riley and Kim Snell, the statisticians, had no conflict of interest, and the conflict of interest by Ronan Tracy and myself was fully declared in the paper. They felt that there was no difference in mortality at 90 days and that there was residual confounding. This is the next important piece of work from Oxford, from Professor Andrew Carr's group. They got their information from hospital episode statistics and the Office of National Statistics, and this predated the setup of the NJR, adjusted for confounding variables including age, sex, caste and comorbidity index, rurality, area deprivation, surgical volume, and years of operation. As you can see, it is a very comprehensive study. Here you can see the death rate following hip resurfacing is significantly lower compared to cemented total hip replacements. When you look at the early results, then the 90-day mortality is significantly different between these two groups. When you look at hip resurfacing versus uncemented total hip replacement, then again there is a significant difference. When you look at early results, then there is a significant difference between these two groups at 11 months. Our study showed that 23 male patients needed to be treated by BHR rather than cemented total hip replacement in order to attain one less death by 6 years. The Oxford study showed that the number of patients needed to be treated with hip resurfacing was 29 in order to attain one less death compared to cemented total hip replacement, and it was 88 when compared to uncemented total hip replacement. Conflict of interest in the Oxford study? No. 90-day mortality difference? Yes. Socioeconomic factors accounted for? Yes. So who do I resurface in 2015? All young active patients who do not have dysplasia or avascular necrosis. I still carry out hip resurfacing in some women with dysplasia, but I'm very careful and I do a CT scan beforehand, and if I can correct all the angles, then I'm still prepared to do a hip resurfacing on these women. Avascular necrosis, I no longer carry that out because I have a better solution. What results are relevant to my practice? Ronan Tracy and myself trained 3 consultants from
Oxford in how to perform the BHR. The next thing we heard was their 5-year results of the BHR were published. They had done 610 BHRs by 37 surgeons, 7 consultants and 30 trainees. It was advertised as a comprehensive review, but no cup inclination angles were reported. We checked how the Oxford results looked on the Oswestry register, and only one patient had been placed on the register. The group from Oxford then started to report on pseudotumours, and no reason was given initially for these strange reactions. I met with David Murray after they started to talk about pseudotumours, and I wanted to try and find out what was the reason for these pseudotumours, and I asked him if I could look at the x-rays of his pseudotumour patients. And he said, no, I'm afraid most of the x-rays have been lost. So I then asked, can we analyse your retrieved components? And happily, he said, yes. The Oxford group sent the pseudotumour patient implants, blind and mixed with non-pseudotumour failures, to Amir Kamali, who's a tribologist at Smith & Nephew Warwick, and all the implants were analysed, and there was a very clear relationship between pseudotumour and edge wear of the cup. So edge loading of the cup in a metal bearing is a really bad happening and will lead to excessive wear on the edge of the cup, and it will cause failure, usually from a metal reaction, fluid-filled hip cavity, or pseudotumours, as Oxford call these. The point about edge wear and the Birmingham hip resurfacing is this. In large patients, there is room for some error in cup positioning, and still you will almost certainly avoid edge loading and edge wear of the cup. However, with small implants, the surgeon must be much more accurate with his cup positioning, otherwise rapidly the load will get taken on the edge of the cup, you will get edge wear, and the patient will have a failure. The problem is that inexperienced surgeons are incapable of reproducibly getting good position of the acetabular cup. And what you find on national level results or international level results is that there is a higher failure rate in women than men. There are 70 publications from Oxford on the subject of pseudotumours. Absolutely awful acetabular inclination angles. The NJR BHR results are contaminated heavily by the work of inexperienced surgeons. So what results are relevant to my practice? Only my own results are relevant to my practice. I thank you.